think you are tired already. I'll try to make it short and sweet, inshallah. Uh, Today we are talking about actually a magic molecule, which is, I think it's a breakthrough in the diabetes medications. And I think it has a lot of secrets still to show in the future. Of course, before we talk about the medicine itself, we have to talk about the cardiorenal metabolic syndrome. I think this is the second time today to hear about it. My colleague Dr. Rafiq talked about it in the morning, but you will hear about it frequently over the coming years. This term was adopted by the American Heart Association, and it's actually an intersection between the metabolic dysfunction with the cardiovascular disease, with the chronic kidney disease. Long time ago, when I was in the medical school, it was called Syndrome X. It's just an observation, which is that they found that the obese person is liable to have hypertension and heart disease and kidney disease. And they thought, I mean, just an observation. And we don't know if this is because he has a bad luck or because it's related to his condition. But nowadays, we could know about the secrets of the syndrome X, and now it is called the cardiorenal metabolic syndrome. Actually, it's amazingly widespread all over the world, and statistics in the United States showing that it's 1 in 3 they have this syndrome, and in the Gulf area, almost the same thing. Other statistics are talking about 50% of the people either they have the syndrome or they are liable to have it in the future. Of course, in the Gulf region, it's again the same idea, it's the same percentage, but usually it starts with the obesity actually. And then, of course, the patient may be obesity, weight gain. After that, the patient will come to you complaining of foggy mind, fatigue, afternoon drowsiness, sleepiness after having his lunch, intolerance to physical exercise, craving for sweets. Even whatever he eats in the lunch, he wants to have sweet. I think maybe most of us are hearing these complaints every day. And usually these complaints are ignored because either we think that if you tell him, go and diet, he tells you, I cannot. Go and exercise. I'm not able. I feel tired easily. And you think that, it's either it's aging problem or loss of fitness. So usually these complaints are ignored until he goes to the next stage, which is, sorry. As we mentioned, it usually starts with the gaining weight and then insulin resistance and then the complaints, which I mentioned to you, and then they go to the cardiovascular. Cardiovascular, we start to find hypertension. This is the most common thing. But it can go up to heart attack, atrial fibrillation, stroke, peripheral artery disease. So it's not like hypertension and that's it. After that, later on, it comes a kidney problem, which usually it's a chronic problem. So it's discovered later on and usually after the time passed already. Now we come to our magic molecule, the dapagliflozine. Maybe you'll be surprised that this is the oldest anti-diabetic medication in the whole world. This molecule was discovered first before insulin before sulfonylureas, before metformin, before all the medications. Actually, its history goes back to 1835, when a French chemist discovered that he got a bitter taste uh, extract from the apple tree bark, and it was just something like it was added to the shelf of the chemistry that time. And physicians after that, they noticed that when they give it to animals or to human beings, they found that there is a lot of sugar in the urine, even if they have normal sugar. And it was just an observation, but they found another side effect, which is severe diarrhea at the same time. So they put the observation that time, and they shelved the molecule or the extract until the middle of the 20th century, when they started again to search for this medication, and they started to know that it's two different things. It's the SGLT1 and 2. 1 is the one which is working on the GIT, and 2 which is working on the kidneys. Again, it was left for until the 1990s, until the molecular biology was advanced, and they start to make only the SGLT2 alone, which works on the kidney in amazing way, of course, that time, because it works on the proximal convoluted tubules, and it works on of course, this molecule or this transporter is the one which makes the kidney absorb back about 90% of the sugar, which goes to the renal blood. So if you give that transporter inhibitor, it means that a lot of sugar, it will go down physiologically with the urine. So hallelujah, thank God, it's great. We found a very magic solution now, a medicine which reduces the blood sugar, independent on insulin. At the same time, no fear of hypoglycemia. At the same time, it's not related to the beta cell failure or beta cell situation, whatever it is. It's away from that. So it was, of course, at that time it was like a magic molecule that say, oh my God, we have discovered something great, and it was put in the market as SGLT2 inhibitor, and we thought that this is the end of the story. That's why I'm telling you it's the magic molecule. The cardiologists took the molecule and started to study it only to know about the safety for the cardiac patients, only for that. And it was a surprise. They found a lot of magic things about it. They found that it's working, making magic to the heart patients. The heart failure patients, they found less hospitalization. They found that they have a bigger lifespan. They found that the cardiac muscle itself is affected positively, the less oxygen demand, and oh my God, they found a lot of things for their patients, and they started to put it as now in a new as a new class of medication for the cardiac patients with or without diabetes. This again, it was the other magic which was discovered about the molecule. Thirdly, of course, I mean, for the cardiac effect on that, it was a bit something funny. Of course, when you have chronic kidney disease, which came after that discovered, of course, it is very good for the kidney disease. That when you have chronic kidney disease, the problem that the SGL2 the transporter itself, it take back the glucose and the sodium. So the sodium doesn't reach the macula densa. it gives the kidney a false impression that there is hypovolemia. So it starts to dilate the afferent arteriole. When it's dilated, the intraglomerular pressure increases. When you suppress the transporter, the sodium, of course, the sugar will come out, but also the sodium also will come out. It will reach the macula densa. It will give the kidney the impression that it's safe now, no problem, we don't have hypovolemia. It starts to constrict the afferent arteriole. So it starts to reduce the intraglomerular pressure. So it starts to improve the kidney function on the long run. All the things which were found for the cardiac and for the kidney things, it was found that, especially for the cardiac patients, it was found that it happens fast. It's not like after 2 or 3 years. They found that it works in weeks or months. And again, hallelujah, thank God. It's a great thing. So now the medicine is put in a different area for the treatment of the cardiac patients with or without diabetes. It's treatment for the chronic renal patients. For the cardiorenal syndrome, of course, I mean, now, if it's that prevalent, like one in every 3 patients, they have the syndrome, or one in 2 patients is liable to get the syndrome, prevention is better than cure. So we want to have something which treat everything together. I mean, we don't want to give a treatment for diabetes. We want to another treatment for the heart, another treatment for the kidney, another treatment for. We're trying to give something which help everything. Prevention better than cure. Okay, so lifestyle is number 1. If you want to save your patient, when he comes to you complaining of the fatigue, foggy mind, tiredness, intolerance to exercise, craving for sweets, craving for food, all the things, if you can start with him the change of the lifestyle, like reducing weight through dieting, through the exercising. By the way, this is not easy. This is not easy at all, because we have in our mind a built-in system. It's called survival mode. Survival mode pushes the human being to eat a lot, to sit without doing anything, and to have a lot of sex. Why? To keep the species going on, because we want to save energy. So we want to. That's why it's very tricky. You know, it's not easy. So you have to advise the patient for dieting, for exercising. At the same time, you have to apply cognitive and behavioral therapy for the patient. At the same time, if you have something which can help everything, again, like metformin, like our magic molecule, it will help everything from the beginning, and it will take the patient safely out of the syndrome. This can save a lot of lives, actually, a lot of lives, because a lot of people are living with these complaints without knowing that they have something serious at all. Of course, again, if we have a look at this magic molecule, I mean, it's showing that a lot of things. It can reduce weight, of course. At the same time, it can help the patient to lose weight. It can reduce the uric acid. It can, it's anti-fibrosis to the heart muscle, of course, anti-inflammatory, because it reduces the fat tissue, especially the visceral fat, by the way. I mean, it affects the visceral fat. And blood pressure reduction, natriuresis. I mean, you can. Of course, I mean, a lot of studies were made about this that declare TMI 58, that declare, again, heart failure. the declirtimide, the DAPA-CKD, regulate. So it was a lot of research which proved what we were talking about just a while ago about dosing and administration. Actually, it's a very easy thing because we have single dose once a day, easy for the patient. It's 10 milligram. You take it better in the morning, with or without food. We have another dose which we were discussing with the colleagues outside, the 5 milligram. 5 milligram, I mean, we don't recommend it except in certain situations, like a bridging for a patient who is on a lot of diuretics and there is electrolyte imbalance. So you give 5 milligram as a bridging only until you secure the electrolytes, and then you can reduce the diuretics, not the medication, reduce the diuretics and go up with the dapagliflozine. Also, if in the frail or very old frail patients, you can give the 5 milligrams again as a test dose just for some time until you are sure that he's secure, and then you go up again to the 10 milligram. For the monitoring, of course, I mean, it's the basic things that you check the EGFR, electrolytes, blood pressure, hemoglobin A1C. After that, you have to make it like every 3 to 6 months, just to know that you are on the safe side, that the patient electrolytes are okay. Blood pressure, because if the blood pressure will go down, you can reduce the antihypertensive medications. And annually, of course, a comprehensive metabolic panel with the cardiovascular risk assessment. Before I leave you, actually, I'd love to leave you with an idea, with a thought. William James, he's called the father of the American psychology. He was a psychologist and philosopher also at the same time, again in the 19th century when the first gliflozine was discovered. So he was by the end of that century. He mentioned that more than 100 years ago, compared with what we ought to be, we are only half awakened. Our fires are damped. Our drafts are checked. We are making use of only a small part of our possible mental and physical resources. And guess what? After more than 100 years, we are using less mental and physical resources than what he was talking about 100 years ago because of the what we call brain rot and the social media and the distractions and all the things. So we are using less and less mental and physical resources. I'd like to leave you with this thought. Just think about it, and thank you very much.